Good morning, everyone. I'm going to talk briefly about when, the two cases of SIH and the management that we did. So the case one was of a 68-year-old female who had hypertension, hypothyroidism, and severe osteoporosis. She came with us with a complaint of postural headache for past 1 month. The history was the onset was relatively subacute of the headache, and it gradually progressed, and such that for the past 7 days it worsened, and she was not able to do her activities of daily living. The headache was holocranial throbbing type and had a mild to moderate intensity, and with a particular history of postural variation. That is, it would aggravate by sitting and standing or walking and get relief by lying down. So, out of this, our differential diagnosis of an orthostatic headache was orthostatic hypotension, POTS, intracranial hypotension, and other differentials were the posterior fossa arachnoid cyst, colloid cyst of the third ventricle, and chiari malformation. As we proceeded with the examination, we found no orthostatic drop, neither no orthostatic change in heart rate. So our first two differentials were over. In the neurological examination was also unremarkable. So we proceeded to investigate the patient. In investigation, we found bilateral subdural collections, and also the descent of the signs of descent of the brain, the pontine distance, it was less than 6.5 mm. All these features were suggestive of spontaneous intracranial hypotension. There was also contrast enhancement in the meningeal enhancement, and also increased the venous sinus distension as well. So for the moving ahead, we did the MR spine and the CT myelography in an aim to localize where the CSF leak might be, so for which there is drop in the there is a causing of the intracranial hypotension. But here we did not find. There were evidence of multiple disc osteophyte complexes in the cervical, in the lumbar region, but we could not find a leak in the CT myelography. So a brief about the diagnostic criteria of the SIH. The ICSD mentions that any headache that has developed in temporal relation to the low CSF pressure or CSF leakage, or led to its discovery, and following either of the following, the having a low CSF fluid pressure or evidence of CSF leakage on imaging. And it is because of SIH if there is absence of a procedure or trauma known to cause the CSF leakage, and headache has developed in temporal relation to the discovery of the CSF leakage. So our diagnosis was SIH in this patient, but we could not localize the site of leak in this patient. The second case was of a 42-year-old female. She had hypothyroidism. She came to us with a short history of 10 days of postural headache. The onset was relatively acute, and from the day after its onset, she was not able to do her activities of daily living. The intensity of the headache was also pretty much high as compared to previous patient. She also had similar postural variation, and as with the earlier case, there was no orthostatic drop, and there was no findings on the positive findings on the general and systemic examination. The neurological examination was also normal. Here, we proceeded with the same protocol. We did the MRI brain, and as was obvious in the earlier case, there was no that obvious subdural collections was not visible in this case. We discussed with our radiologist man. We could find, though, there is a thin sleek of CSF collection, thin sleek, very thin sleek. So, keeping in mind of the history and a suspicion for the diagnosis, we moved ahead. We also found out contrast enhancement in the T1 images, and here the MRI spine did not. There showed some ligamental flavum hypertrophy and some disc or osteophyte complexes. The CT myelography here showed the leakage in the lower cervical and the upper dorsal area in the CT myelography. So here we found the site of leakage. So as obvious, the diagnosis became the SIH due to a CSF leak. However, in the treatment, we went for a blind epidural blood patch in both the cases. And to our surprise, both the cases responded well to our blind epidural blood patch management during follow-up. So the common thread was both the cases were having orthostatic headache. The MRI brain signs of intracranial hypotension were there, more obvious in the first case, and both the cases showed improvement with the epidural blood patch. In case 1, the leak was not localized, and in the case 2, there was a definite dorsal leak. So, what is the clinical manifestations of SIH? Obviously, the postural headache is the most common. And apart from the headache, there can be other symptoms such as nausea, vomiting, neck pain, tinnitus, dizziness, hearing disturbances, other visual symptoms such as blurred vision, diplopia, vertigo, back pain. So these are the rare symptoms of spontaneous intracranial hypotension. What can be the predisposing factors? Hypermobility disorders such as the Ehlers-Danlos syndrome, Marfan syndrome, and trauma, however trivial it can be, can cause CSF leakage. There was a CSF spinal leak classification given by Schneeblich et al. Type 1 is the dural tear, type 2 is the meningeal diverticulum, type 3 they refer to as CSF venous fistula, and type 4 is unknown or indeterminate cause. The treatment options remain conservative. Treatment remains the first. The bed rest, hydration, analgesics, and abdominal binders. Pharmacological treatments include caffeine, theophylline, and corticosteroids. Greater occipital nerve blocks have also been shown to decrease the headache part. And epidural blood patch is a bit invasive, but not as invasive such as the surgical options, such as the laminectomy and dural tear repair. So here is a systemic review and meta-analysis from JAMA, where it has shown the treatment options and their outcomes in cases of spontaneous intracranial hypotension. Here we can see that the first epidural blood patch, the efficacy can go around 60%. Non-targeted and targeted, both the efficacy of both the procedures are almost relatively similar. However, they have also mentioned they have found a difference between efficacy of the small volume and the large volume epidural blood patch. So to take home messages, multimodal imaging is an essential in cases of spontaneous intracranial hypotension. Don't rule out SIH if imaging is negative, but symptoms are classic. Orthostatic headache plus pachymeningeal enhancement should be kept in high suspicion of SIH. Epidural blood patch early, preferably large volume, improves short-term success, and we should try to localize the leak if possible. And in cases of persistent and recurrent cases, we should consider for surgical repair. Thank you.
Thank you, Dr. Arijit. I would request our respected panelists to kindly open their lines for questions.
Thank you very much for excellent cases. Just I was wondering, maybe a bit silly question. Shubhalan, is it possible to differentiate between some enhanced MRI? Like, can you differentiate reliably whether it is infective pachymeningitis or it is a pachymeningitis due to kind of a spontaneous intracranial hypotension? I think non-contrast, but contrast enhanced MRI is done.
Yeah, contrast enhanced MR that the enhanced.
Pachymeningitis or infective looks almost 10.
Yeah, but these are actually very even and mainly on the convexities. Mainly on the convexities in the frontoparietal area and bilaterally symmetrical. But in case of your pachymeningitis, it will be nodular, it will not be bilaterally symmetrical. To very hypo in case of pachymeningitis. And here, this will be flare hyperintense because these are the venous engorgement which is happening. So obviously, clinically, you can differentiate it. MR-wise.
I'd like to add the classic enhancement of spontaneous intracranial hypotension is smooth and even. It is not smooth and diffuse enhancement. it is not a nodular or a disaggregated enhancement. There is hardly anything actually in neurology where there is a both smooth and diffuse enhancement in the MRI.
Talk about brain sag. That is, you just don't see only the enhancement.
Yes, there are many other.
Yeah.
There is a Burns index, which there are several markers given points. So if there is a moderate to high probability, you should always suspect SIH. And as Dr. Arijit showed, if there is this high index of suspicion is there, even if you don't find a leak, then a blind epidural blood patch is very effective. It should be tried in all patients where we are suspecting SIH. The classical imaging findings are present.
Yeah. So I think that when you see, you don't not only see the contrast, the smooth contrast, diffuse contrast happening in the convex cities and along the brain, but you also see the brain sag. I mean, there is a descent of the brainstem. There is a crowding in the posterior fossa. There is a distension of the transverse sinuses. So these all add up to your radiological features. And remember that even then, about 5% of the patients with SIH may have a normal MRI. So MRI, if the suspicion index is very high, a normal MRI does not rule out SIH. Then you have to go in for other modalities.
Another question is that spontaneously maybe intermittent. So it is possible that in one your moderators of investigations, maybe the leak may not be the visible at once. So is it there is any kind of practice parameter that they repeat the procedure in the future if one kind of CSF leak imaging is not evident in the first place?
So for I know, we go for that contrast myelo. Yeah. So that usually shows the site of the leak, but it may not show. It's not that in 100% of the cases you will be seeing that. So obviously in those cases you go for blind blood patch.
To take from Dr. Shukalan, I'm a pediatric neurosurgeon. So for the second case, say for example there was a demonstrable CSF leak in the CT myelogram. You did an epidural blood patch, and say the symptoms are not improving. Is there a role for a repeat CT myelogram to see if the epidural blood patch has been effective, and if yes, when do you go for it?
The protocol for is the blind patch, the targeted and the blind, both we can do. And if we did the blind procedure and we followed up the patient, initially the patient response is pretty good. If suppose we don't get them, there is a protocol for a repeat blind epidural blood patch also, then it can also be tried. And if in cases of recurrent and resistant cases, then we have to repair the cause of the leak.
Dr. Arijit? So I think that I'll answer that. You see that if you basically want to find out the leak. When you know that it's a SIH, you want to find out the leak. Because obviously if you are targeted blood patch you are giving, then that will yield a better result. That will seal up the area, the leak area, better than if you do. But then there are lots of studies which have shown that even if you give a blind patch, the patient. But idea is to find out the leak. Now for that the CT myelo is one, but that is again a crude kind of thing. What Sheving does is basically a dynamic CT myelo, and it takes both the sides and that is spaced over 2 days or 3 days gap. So first one side and then one side, right? And then they can identify that not only there might be a leak, that is a common cause because of a spur of but then there can be the type 2 or type 3 anomalies, right? And those will not be readily amenable to the blood patch. There you have to do a surgical intervention. So, to answer that question, that why do the surgeons come in, is because that if you want to have that idea, you have to go in for an extensive investigation. So it's not simple. In some patients it's simple, but in some patients it might be very, very, I have one patient from US. I'll share this thing to you because it is interesting. So I'll just take a minute. So he was suffering from this headache, for the last 3 years, and he has shown to all the places. He's an Indian origin, but he is born there and completely American. So he has shown UCLA and everywhere, right? So he comes to me to show me, and it's labeled as a chronic tension type headache, young man not able to attend the school, colleges. And because what happens that after some time, this postural component goes off, right? And it becomes a chronic daily headache, right? So chronic tension type headache was the level. And the clue I found is this, that he had some, gastrointestinal problem for which he was operated. And he was there in the hospital. He said, "Oh, doctor, I remember that when I was in the hospital and in the bed, my headaches actually went off." So that was the idea I got, that he had this postural element which was missed. And then we did the thing, and then the patient went to Chevy, and he got this thing. So there was a type 3 lesion for him, for which he was having this headache. So at times it becomes a very difficult journey for the patient. So 3 years, having this, and until unless you suspect, you are not able to diagnose that.
About the volume of blood that should become volume.
So I think what you have said, that this again is a variable thing. I think 20 ml will be a reasonable thing. We had a few patients with us. Another thing for neurosurgeons to understand is this, that many patients may come to you with the features of subdural hygromas or subdural hematomas, right? So non-traumatic subdural hematomas, you must ask and keep a suspicion of SIH, because that might be a presenting feature for that. So I think 20 ml would be a reasonable. 20 ml is a reasonable one.
Sir, is there any guideline regarding when we should go for the conservative management and when we should, any time frame like?
No, it depends on the patient's symptoms. If the patient is not improving, patient is having persistent headache, and these patients are severe, they will complain to you. Then you have to go in for
And in some of the discussions in the headache conferences, we have heard that gradually these patients tend to change with the character of the headache. Like the patients, they later on they do not manifest the postural kind of.
That's what it said.
And sometimes they get the reverse kind of.
Yes, that is also visible. I've seen 2 patients where it was reversed, but that happens after a year and a half, 2 years, something like that.
Here in our setup, like the anesthetists usually try when they do the blind blood patches, they usually try for 3 or at least 3 blind blood patches in 3 different times, because their experience is that a single blind blood patch usually fails. So they do in 3 different days.
It's variable because there is no randomized data on that, but of course, you may have to do a multiple blood patches.
Thank you.
Thank you so much. I would like to request Dr. Arijit to please come.